Okay, over to you, Marianne, to kick it off.
Hello, everyone. I'm Marian Tabi, and welcome to the WHO Africa Media Briefing. Today, we will be providing you with updates on the ongoing health emergencies in the region, including cholera, the health impacts of flooding in Southern Africa, and other health threats across the region. This briefing is available in English and French, so please feel free to select your preferred language by turning to the globe icon on the bottom right of your screen. Now, joining us from Brazzaville is Dr. Marie-Roseline Belize. She is the Regional Emergency Director at the WHO Regional Office for Africa. We also have from Maputo, Dr. Severin Zilanda. He is the WHO representative in Mozambique. Also on board is Dr. Laurent Musango. He is the WHO representative in Madagascar. Dear panelists, a warm welcome to you all. I will now hand over to you, Dr. Belize, for your opening remarks.
Good morning, bonjour, and thank you for joining us today. So our continent is managing multiple overlapping public health threats driven by climate shocks, infectious diseases outbreaks, and humanitarian emergencies. These crises are interconnected and demand coordinated action. In the first 6 weeks of this year, up to 15 February, the continent reported nearly 16,000 cholera cases. In southern Africa, cholera cases have risen by more than 7 times compared with the same period last year. The cases are being reported from Mozambique, Malawi, Namibia, Zambia, and Zimbabwe. Mozambique accounts for the majority of reported cholera cases, particularly among flood-affected and displaced population. Extensive floods due to cyclone and have damaged water and sanitation systems, contaminated drinking water sources, and displaced communities, creating conditions for rapid transmission of cholera and other waterborne diseases. Risk analysis indicated that a critical transmission window between March and August. Intensified prevention, disease surveillance, and vaccination efforts are essential to prevent further escalation. We are coordinating with our partners and supporting national authorities to strengthen emergency response, prevent the spread of diseases, and ensure continuity of essential health services. Beyond cholera, vaccine-preventable and vector-borne diseases such as malaria and dengue are resurging. A multi-country diphtheria outbreak has affected 8 countries since 2025, with more than 26,000 suspected cases and over 1,300 deaths reported. Up to 95% of cases are among unvaccinated or under-vaccinated children. Strengthening routine immunization, expanding catch-up campaigns, improving laboratory confirmation, and ensuring access to diphtheria antitoxin remain urgent priorities. Across the meningitis belt in West Africa and the Sahel, we are closely monitoring the situation as the dry season progresses. Early detection, rapid laboratory diagnosis, and pre-positioning of supplies are critical to preventing large-scale outbreaks. In Nigeria, Lassa fever cases are rising with several deaths reported in a number of states. National authorities have activated response measures, and WHO is supporting coordination, treatment, and risk communication efforts. And to share some welcome news, Mpox trends across the continent show a significant decline in recent weeks, with confirmed cases falling by more than 30%. But vigilance remains critical. Across these outbreaks and climate-driven emergencies, the strength of our health system and their capacity to anticipate, prevent, and respond effectively are fundamental. As extreme weather intensifies, displacement rises, and infrastructure comes under severe strain, health systems must be equipped to manage multiple overlapping risks simultaneously. WHO will continue to support member states through strengthening disease surveillance, rapid response, expanded laboratory capacity, vaccination, and delivery of essential medical supplies. With a strong national leadership, sustained investment in a resilient health system, and coordinated regional action, we can manage these risks and protect the health of our community. Thank you, and over to you, Tabi.
Many thanks, Dr. Belize, for those outstanding updates in the region. I will now turn it over to you, Dr. Severin. Could you share with us Mozambique's response to the crisis, the challenges and efforts to address these challenges, and also some of the lessons learned? Over to you, WR. Doctor, you are muted, please.
I'm terribly sorry. Okay, once again, thanks, Marianne, and good morning, bonjour to everyone, boa tarde. Thanks for attending this press briefing, which demonstrates your interest in the situation of the sub-region. Mozambique is currently one of the most affected countries by flooding and cholera surge in southern Africa. The country accounts for 90% of the more than 4.3 thousand cholera cases reported in the sub-region between January and February. The floods have caused extensive damages to key infrastructure, including health facilities. 181 health facilities have been affected, schools, roads, particularly bridges, as well as water and sanitation. More than 700,000 people have been displaced. The most at risk are displaced communities living in temporary shelters, often in crowded situations, with limited access to clean water and health services, particularly children and pregnant women, and women in general are particularly vulnerable, also exposed to gender-based violence. WHO and partners are supporting the government of Mozambique with essential medicines and supply, reinforcing disease surveillance, deploying rapid response teams, and providing technical support on case management and infection prevention and control. In addition, WHO is supporting the emergency response vaccination with oral cholera vaccine in 4 districts in the provinces of Det and Nampula, targeting 1.7 million over 1 year of age. Community engagement is also a priority. We are working with the authorities and partners to ensure people know the warning signs and seek care early. Looking ahead, our risk analysis flags a highlighted transmission period from March through August, particularly if flooding continues or access to safe water remains limited. We are focused on staying ahead of the curve. WHO remains closely engaged with national authorities and partners to contain this outbreak and assist displaced population and protect community. Thank you very much indeed. Obrigado.
Merci beaucoup, and thank you very much, Dr. Severin, for those updates from Mozambique. I will now pass the mic over to you, Dr. Laurent Musango. Could you tell us about the impact of the recent cyclone and flooding on health in Madagascar? Tell us, how is the country responding to this and what support WHO is providing? Over to you, WR.
Merci beaucoup et bonjour à tout le monde. Merci, Mariam. Je voudrais vous dire qu'entre fin janvier et février 2026, Madagascar a été frappé par deux cyclones successifs. Il y a le cyclone tropical Fitia qui a touché terre le 31 janvier, suivi du cyclone tropical intense Gizani au début du mois de février. Ces événements ont entraîné des impacts humanitaires et sanitaires majeurs, particulièrement dans les régions de l'est du pays, incluant l'agglomération densément peuplée qu'on appelle Toamasina ou Tamatave. Et ceci apparaît dans un contexte où nous avons une épidémie de Mpox qui est en cours dans le pays. À ce jour, les données officielles consolidées que nous avons eu 430 000 personnes qui ont été affectées, dont près de 15 948 personnes déplacées, avec 804 blessés et 62 décès malheureusement. Et 13 personnes ont porté disparu. Les destructions sont vraiment importantes avec plus de 25 000 habitations totalement détruites et près de 49 129 habitations totalement endommagées et plus de 14 330 habitations inondées, exposant ainsi des milliers de familles et des conditions de vie qui sont précaires. Et face à cette situation, le gouvernement de Madagascar a officiellement lancé un appel à l'aide internationale le 14 février dernier, afin de mobiliser un appui supplémentaire pour la réponse multisectorielle. Ainsi, pour cette réponse multisectorielle, nous avons fait une descente dernièrement avec le Premier ministre, chef du gouvernement, avec le ministre de la Santé, le coordonnateur résident et certains représentants des agences des Nations Unies, inclus moi-même. Et pour la santé, nous appuyons la coordination des partenaires et nous avons fait une réunion de tous les partenaires pour harmoniser les activités de coordination. Autre chose, nous avons aussi déployé une équipe de ressources humaines et matérielles de l'OMS pour appuyer. J'ai présentement 5 personnes qui sont sur place et qui travaillent avec le centre d'opération d'urgence régulièrement, mais aussi nous continuons à appuyer la communication et les risques afin d'éviter et de prévenir les risques. Nous avons donné 7,8 tonnes de médicaments essentiels et intramédicaux qui ont été acheminés sur place, même avant en termes de prévention, de preparedness, et pour que les communautés affectées puissent maintenir l'accès aux services de soins. Merci.
Merci beaucoup, Dr. Laurent, pour cette mise à jour. Now that we've heard from all our speakers, we will now open the floor to you journalists to ask your questions. Please make sure you use the Q&A function in the Zoom application to ask your questions. Remember to put in a name and the name of the media organization you represent. I will begin with these questions we received from some journalists, and this question is coming to you, Dr. Severin. With limited cholera vaccines available, how is this affecting the cholera outbreak response in Mozambique? Over to you, Dr.
Thank you for the question. Actually, the DG announced 10 days ago that Mozambique was the first country that received a cholera vaccine for preventive purposes. So the shortage of cholera vaccine is seeing the end. I'm not saying it's over, but certain countries, including, luckily, and thanks for that, Mozambique is preventive for availability, better availability. Indeed, in this reactive vaccine round in the 4th district that I mentioned, we are going to apply the 2-dose strategy, which is the recommended one. But in the past years, because of the shortage of the vaccine, we applied only 1 dose when we did the reactive vaccinations. But as you know, the vaccination for cholera is only one element of cholera control, and is obviously gives a certain level of protection, but does not lead to elimination of the problem. So therefore, the classical approaches of improving water and sanitation, safe water sources, and appropriate case management, targeting it of a case fatality rate of less than 1% remain the main elements of cholera control, including in Mozambique, where there is a large experience. And I think I have to say that the investments that have been made over the years in strengthening the capacity of the country to prevent and control are yielding results. Thank you.
Thank you, Dr. Dr. Belize, do you want to weigh in on this question? Over to you.
The WHO expressed that I take out for any outbreak response, the vaccine is a tool that support. But for an outbreak, we have a more other, for example, the treatment center that should be set up, also the clinical care that should be given. It's also very important in cholera that rehydration should be put in place, and that it's part of the clinical care that electrolytes should be given to the patients really quickly in that case. So we also have the prevention and control aspect that WHO is really supporting the country to put in place, you know, that, and also the drinking water. So cholera is a vector-borne disease. A clean access to clean water is also essential to control cholera. As the WHO mentioned, this vaccine will be preventive. That means that there will not be a reactive vaccination. So because when you have the outbreak is already there, you respond to it. We put in place a reactive vaccination. But to prevent it, we can also go further, as we do, for example, for measles, for diphtheria. And Mozambique has been one of the first countries to receive that cholera vaccine for preventive, to prevent future outbreaks. So, however, we continue to support the response with the tool available so far, like a very good clinical care, make sure that every patient have access to health system, to clean water, and then the electrolytes are available. We also make sure that those patients receive the information that they need in order to protect their lives. Thank you.
Thank you, Dr. Belize. And still with you, if you can tell us the impact of the recurrent public health emergencies on the ability of the region's health systems to adequately support populations. Still on you.
This is a very important question. So I take the short answer is that health emergency do not increase, do not only increase demand for care, but they also simultaneously weaken, the health system wherever this emergency occurring. So we remember COVID-19 and also all those countries were having an outbreak. So that means to provide that care, it's really important that we put in place a double pressure that affect the ability of that system. So we work with the country in four aspects. The first one is that we make sure that routine health services are really are not disrupted, I can say, you know. So when outbreak, climate-related disaster or conflict occur, it's important that resources to emergency response should be timely there. So this is what we do. We graded the emergency in order to have access to funding so we can respond quickly and make sure that there is no disruption in the health system, because those, for example, women who need to deliver should still have access to this health system. So we work with the ministers in order to make that. So the second thing that we do when we are facing those very big emergency is that healthcare workers are also protected. You know, when the system, like in Mozambique right now, in Madagascar, facing there's increase of emergency, the healthcare workers straight to their limits. So it's important for us to make sure that those people are not really, I can say, overwhelmed, and then they're operating with enough public health and healthcare workers that they need. So most of the time we support a surge. So far in Africa, we have trained more than 2,000 surge in more than 24 countries. And we make also in place like we call a solidarity. We can take people some countries to deploy to another countries, of course, with the national authorities request. After the national authority request, so we can support this surge and deployment in order for the healthcare workers also to have more hands to respond to this. The third thing that we do is also we support with supply chain, because we're doing those emergency, normal supply chains in the country become very fragile. Dr. Laura mentioned that WHO has supported the response with 8 tons of essential drugs during that response. So it's also important that we sustain it. Reason why we will see that in the region we have 2 warehouses where we preposition material that that can be quickly deployed to those countries. We have one in Nairobi and also another one in Dakar. And there is in the pipeline maybe to have another one in another sub-region in the continent, so that can facilitate the deployment of those medical supplies when they need. So we also have the fourth one I can say is the financial criteria. During emergency, we also have a financial pressure that can increase, and mostly in the countries with a very low income, and the country also where they are already fragile responding to humanitarian condition, and then they have more outbreaks. So what we do, we work with the government, and we have also the CFE, that is the contingency fund for emergency, that is replenished by member state and also by donors. So we quickly release that funding in order to, in the first 48 hours, for the country to have these financial resources available. A last thing I can say is that I have to mention maybe is that during those emergency, as you can see, we have that inequalities that become riding, that become very bigger. So those inequality and also equity. And with WHO, we make sure that wherever the emergency is happening, rural communities, displaced population, and those also living in this fragile condition are not leaving behind, because those people most of the time they are disproportionately affected by emergency, because they are already in emergency. So we make sure that the resources that we send can reach them wherever they are, in whatever the place they are and they are affected. So we make sure that it is. So I can stop there, but importantly I can say it's not only an immediate action. So because during emergency, we have to make sure that immunization campaign continue. That it's important, for example, that polio campaign can continue, that children have access to routine immunization, that there is no disruption in any services, that people with a condition like HIV, tuberculosis, diabetes, non-communicable diseases, they still have access to their treatment. So in summary, what I can say is that when those health emergency ongoing, that really place a significant strain on the health system. But however, so we have so many guidelines that we work with the country in order to support them and to cope with those emergency, and for the health system also to be resilient. Thank you.
Thank you so much. Thank you so much, Dr. Belize. We do have a question that will come to you. The two WRs here can also weigh in. And this question is from Shisia Wasilwa. Her question is, with cholera vaccine supplies only recently improving after years of shortage, what concrete measures is WHO taking to ensure countries like Kenya receive sufficient doses for both emergency response and preventive campaigns in high-risk counties? Dr. Belize, you can start.
The question with the shortage of vaccine?
The question with cholera vaccine supplies only recently been approved after years of shortage. So She is asking what WHO is taking to ensure that countries like Kenya receive sufficient doses of this vaccine for emergency response and also for preventive campaigns in high-risk counties.
And so maybe I can start by saying that we have global mechanisms that we call ICG. It is the global mechanism for vaccine allocation. And cholera, some vaccine, not all of them, but cholera is one of them. So this vaccine is allocated based on certain risks, epidemiological risks, spreading of the disease. So we have some tools that we assess, okay, the risk of the country. So we can see if the risk is high, moderate, or low. And if the spread is also high, moderate, or low. So we have the risk assessment that we do for the country. And we see if it is really, I can say the data, the epidemiological data also should be available, because those I can say when the vaccine is giving to a country, is not giving just because there is a need. There is an assessment. Epidemiological data are also important. We also look at the population, the affected population. So the urgency of the vaccine for the country is because it's a tool to save lives, So the vaccine is not given for the country to put in storage. It's giving for the country really because after we assess all those risks and we and the risk is classified, and then we send it to this committee. In this committee, they meet and they allocate the vaccine based on the risk that we conducted in the country. So this is how this vaccine is allocated to some countries. And it is for the global. It is not only for Africa. The ICG is also for all the world, because we also have other countries that are not in Africa affected by cholera, like Haiti, where we have the biggest cholera outbreak still ongoing since 2010. So this committee is also the same that is responsible for the allocation of vaccine of cholera.
Many thanks, Dr. Belize. I'm now turning it over to you, Dr. Laurent. We have a question from Frederick Lichuma from Citizen TV, and he's asking if we do have an estimate or figure of those affected as a result of the cyclone. Maybe you can start by giving us the situation in Madagascar, then Dobra in Mozambique can weigh in. Over to you, Dr. Laurent.
Merci beaucoup, hein. C'est une question intéressante. Je voudrais revenir sur les personnes affectées par les cyclones. Et il y a eu 430 000 personnes qui ont été affectées de façon globale. Vous voyez que c'est un chiffre très élevé, avec à peu près 16 000 personnes qui sont déplacées, donc qui ont abandonné leur maison d'habitation et qui se trouvent en dehors de là où ils habitaient. Et malheureusement, j'ai déploré 62 décès que nous avons eus et 13 personnes qui sont disparues où nous ne savons pas là où ils sont. Alors, ça, c'est ce qui concerne les personnes. Et avec d'ailleurs 804 qui sont aussi blessés. Maintenant, c'est ce qui concerne les personnes. En ce qui concerne les infrastructures et les habitations, nous avons eu 25 000 habitations qui sont totalement détruites et près de 50 000 habitations endommagées totalement. Et 15 000 habitations inondées ne sont pas détruites, mais les gens ne peuvent pas accéder à leur habitation à cause de l'eau qui avait inondé ces habitations. Donc, vous voyez des milliers de familles qui sont dans des conditions précaires et qui nécessitent les services de santé. Alors que ces services de santé sont totalement détruits. Et nous estimons à peu près 300 000 personnes qui ont besoin d'assistance sanitaire. 300 000 personnes qui ont besoin d'assistance sanitaire dans un contexte où nous avons eu 36 formations sanitaires qui ont été totalement endommagées, incluant 2 hôpitaux universitaires de référence. Les hôpitaux universitaires qui avaient les services de maternité avancée, les services d'imagerie, les services de chirurgie, et j'en passe. Et si on prend tous ces aspects, nous avons fait une estimation de besoins et c'est autour de 7 millions de dollars pour couvrir un peu ces besoins prioritaires dans le domaine de la santé. Je pense avoir répondu à la question et je vous repasse la parole. Merci.
Merci beaucoup, Dr. Laurent. Now passing the mic to you, Dr. Severin, on the estimate of those affected as a result of the cyclone in Mozambique. Over.
Yes, as I mentioned, 700,000 people have been displaced and 181 health facilities have been affected. Meaning, even if the people return from the temporary housing centers, which they do, it is not the end of the crisis. As my colleague from Madagascar, Laurent, mentioned, houses have been destroyed, fields have been destroyed, the crop has been lost because there was just the plantings here, so there will be probably food insecurity in the future. The number of vector-borne diseases after the withdrawal, the lowering of the waters will lead to increased surge of malaria. We are expecting in areas where malaria has already been largely controlled. So we are currently, I can't give you precise figures at this stage. We're working on a recovery plan. One element that the government is paying a lot of attention, including with support of partners, including WHO, is to building back better. That means that health facilities that are built better to be resilient to climate shocks, being not only floods, obviously, but also the cyclones, which is possible with physical alterations of the constructions. But the population will need support in a context where Mozambique is one of the poorest countries in Africa and is facing multiple problems apart being one of the most vulnerable for extreme weather effects. Also, it has a crisis, protracted humanitarian crisis due to a conflict with non-state armed groups in the north, and a total of 4 declared public health emergencies. So you can see it is a difficult situation and the needs are enormous. Over.
Thank you, Dr. Severin. And still on this question and back to you, Dr. Belize, do we have an estimate of those affected in the region?
So as we mentioned at the starting of this media briefing, so we have other countries other than Mozambique, Madagascar. We have also Malawi, Namibia, Zambia, and Zimbabwe in the Southern Africa that are also affected by cyclone and also are having a displaced population. So far, the estimate is more than 1.2 million for the Sul region. And we are working with all those countries in order to continue protecting the life of those people who are displaced, who are facing this, I can say, emergency. And we are also working with the government to put in place the system that we already described, like the representative of Mozambique and Madagascar have described. So we have a similar ongoing also in those countries that are not here in the media briefing today.
All right. Thank you so much. And just to indicate to our audience that we do have additional experts on board, Dr. Patrick Otim, the Program Area Manager for Emergencies at the WHO Regional Office for Africa, who has joined us and will respond to your questions if needed. We'll move over to a question from Brian from Virtual Strategies. And his question is, how is WHO collaborating with Ministry of Health to combat emergencies? I will start with Dr. Laurent, then Dr. Severin can weigh in. Dr. Laurent, over with you. How is WHO collaborating with Ministries of Health to combat the emergencies? Over.
Merci beaucoup pour cette question importante. Et vous savez, l'OMS vient en première position en tant que chef de file des partenaires Et comme je disais, juste après la déclaration du cyclone, le 12 février, la déclaration de l'urgence le 12 février, nous avons une réunion avec le Premier ministre et planifié une descente sur terrain avec le ministre de la Santé. Et bien sûr, il y avait une équipe technique qui était là bien avant pour la préparation et la réponse. Et nous avons fait une descente où nous avons organisé une réunion de tous les partenaires qui œuvrent dans le domaine de la santé. Et tous les partenaires ont répondu à l'invitation. Ils étaient là où nous avons discuté sur une collaboration, une harmonisation des activités avec une très bonne cartographie des réponses pour éviter la concentration des partenaires à un seul endroit et éviter les autres endroits. Ça, c'était la première chose. Deuxième chose, c'était les déploiements aussi. Les déploiements qui doivent être coordonnés, mais je voudrais aussi souligner que nous collaborons aussi avec les autres agences des Nations Unies, inclus l'UNICEF, UNFPA, OCHA, d'ailleurs, qui coordonne tous ces aspects humanitaires. Et cela aussi a facilité de faire cette cartographie des besoins pour qu'on puisse répondre en fonction de priorités du gouvernement et éviter de disperser les gens. Il y a aussi l'armée, les médecins militaires qui se sont ajoutés aux équipes, ainsi que les étudiants de la faculté de médecine. Et tout cela dans le cadre du CUSP. Du CUSP. Le CUSP coordonne de façon régulière les réunions des partenaires et nous avons les membres de nos équipes. L'incident manager participe et coordonne toutes les activités avec la partie gouvernementale. Donc, nous privilégions les priorités du pays et nous sommes vraiment avec le ministère pour coordonner les activités en fonction de leurs besoins. Over to you.
Merci beaucoup, Dr. Laurent. And turning the same question to you, Dr. Severin, on how WHO is collaborating with the Ministry of Health to combat emergencies in Mozambique. Over.
Okay, well, it's not very different from what Laurent described from Madagascar. WHO being an intergovernmental organization, our main support goes to the government. And in Mozambique, the government has been very proactive in response to the floods and declared a national emergency, as actually the entity that is in charge for catastrophe management is ENGD. It's called ENGD. They basically dislocated the National Coordination Center to the crisis from the capital Maputo to Xai-Xai province, to Xai-Xai, which is the head capital of Gaza province, where the floods were occurring, and gathering all the partners around them. And we supported, obviously, the national response. WHO is also in Mozambique. We have the cluster system activated. So we have a health cluster and we have a WASH cluster, and WHO is the lead agency for the health cluster. So we have been similar to what described Laurent, coordinating the partners on the ground to make sure, working with NGOs and UN agencies, the same that Laurent mentioned. In addition, IOM plays here also a quite important role in support, but obviously also with NGOs, particularly the ones that working in health, such as MSF, a very close collaboration also with the Red Cross family, all partners that are engaged in humanitarian emergency response in Mozambique. There's also a lot of bilateral support that was coming in, and that is all being coordinated by the National Emergency Coordination Center and the cluster system. So as I always say, WHO, we work primarily with the government, through the government, supporting the Ministry of Health. We have them provided also financial and logistical support, pre-located medical supplies and equipment, so that and to compensate the out of stocks that has been created by the floods. I think that's what I can say to this. Thank you very much. Over.
Many thanks, Dr. Severin. It is my understanding that we have a live question from Paul Adepuchu Paul, please go ahead.
Thank you very much for taking my question, and many thanks for the experts on this call today. We've heard a lot about how we respond, the continent experts are responding to these emergency situations. But my question is focused on predicting these severe weather conditions and how they can impact lives. So I would like to know the extent of the capabilities of both countries that we are discussing today in predicting these severe weathers and what preemptive measures were taken such that the experts can actually minimize the impact so that we are not just having a responsive approach, but predicting and preparing for what our prediction models are saying. So are the prediction capabilities expansive enough, and or what is the issue in preparing for these severe weather conditions before they actually happen? Thank you very much.
Many thanks, Paul. We will start with Dr. Belize, then we will move over to our two WRs. Over to you, Dr. Belize.
Thank you, Miriam, and thank you also, Paul, for the question. So before I give some element of response to Paul, I would like to add something to what the WHO mentioned and how we collaborate with the ministries of health and also the government in globally. So they really describe very well, what it means to collaborate with the Ministry of Health at operational level, but at the strategic level, we have what we call the Health Emergency Prevention and Response and Resilience Framework. So with the acronym is HEPR, HEPR. So it means it is a framework that has been published in 2023 that really give us, I think, the orientation on how to collaborate with to work with the Ministry of Health. So this framework also highlight the 5 C's. The first one is the collaborative surveillance. I think they mentioned that they have to strengthen the early warning system when we have an emergency. So they also mention the community protection. When we are engaging with community to build resilience, those who are affected, we mentioned that, and they also mention it in there. So the third C is the clinical and scalable care. So during emergency, we also ensure that the healthcare system can handle the surge in patients. I think I explained it before, also how with the surge, healthcare workers, when the request comes from the government. The fourth C is access to countermeasure. So it's important because, Laura mentioned that we have given 8 tons of supplies in order to secure a equitable access to those. And we also mentioned a vaccine that Mozambique will be the first to benefit from the preventive cholera vaccine is also part of the access to countermeasure. And the fifth one is the coordination. They mention it, how we coordinate also at national level, to how the health cluster are supporting to coordinate, how they work with the ministry hand to hand with the Ministry of Health in order to make sure there is no duplication, there is a synergy of work, and then we save those population in need. So now come back to the question of Paul. How I think we respond also. So what is the focus on preparedness? As you know, the emergency program in AFO, we have 4, I can say, branches or 4 domain area, program area. We have the preparedness, that is really big, the biggest one. We have the emergency response. We have also the information surveillance and laboratory, and we have the logistic part. So preparedness also, they are really working hard. And I think this is the area where we have the most work ongoing. But most of the time, this is an invisible work, because this work we do it behind the scene. And this is how we assess country capacity. If you recall, Paul, we also have the International Health Regulation. That is a binding document that has been approved in 2005 by the World Health Assembly and entered into force in 2007. So these international health regulation pave the way on how we should work. So the country is mandatory that they submitted their capacity to respond every year. This is what we call the ISPAR. The ISPAR is an acronym. and they have to submit a mandatorily to say what is their capacity, and we assess. So far in Africa, when I think in 2020 we were at a 48% globally in the region of capacity putting in place, and we have increased. I think now we are at a 50.2%. This is I can say from 48 to 2, you can say this is not, but this is a lot of effort of putting in place. Country also assess the capacity, but we call the joint external evaluation, the joint, what we call globally the GEE. So far, all the countries in Africa have conducted that joint external evaluation, where we have external expert going to those countries to assess all the domain of intervention of an emergency, and we have the capacity of the country. We also have what we call the STAR, which is the strategic tool for assessing risk. The STAR gives us the seasonality of those risks. That means we know when, in which period. Reason why I can tell you that from January to August, we will have the cyclone, for example, in the certain Africa. So we have those tools that we really collect the data. We also have the VRAM, the Vulnerability Risk Assessment, conducted in some countries that take into consideration those climate change risks that are not taken into consideration in the STAR. So now what we do, we have pulled all those risks, all those data together in a new tool that we will be sharing soon with the public. And this tool can predict, can tell you, and can inform you in advance which risks your country could face in the next 15 days, in the next month. So it is how we are making the predilection, and this tool has a modeling integrated that is really, I can say, 95 to 99% accurate that these risks will also, that this event will occur. I think soon we will have a media briefing where we will share those tools. So now, how countries are preparing? I mentioned before that we have preposition of material that we are needed, and at country level, the W also can give what they do. I think almost all the country, they have what the women resources that are doing those assessment of risks, and what we prepare. In terms of human resources, we know who should be in place. Also at the hospital, we preposition also the material that they will need. For example, for meningitis, we know that in the belt, meningitis belt, we have to expect that we will have some meningitis case. And we send those kits to the country, and they are prepositioned in the district, in the commune, in the arrondissement, where there are more risks for those emergencies to occur. At regional level, I already mentioned that we have these tools that we monitor for the country, and we send the country a message to tell, hey, be careful, this risk has to happen. You have to be prepared. So there are a lot that is being done in the preparedness side. I can maybe share to Patrick, you can add more on that.
Thank you so much. We'll move first to the WRs to tell us the various predicting capacities and preventive measures, starting with you, Dr. Laurent.
Merci beaucoup. Merci à Paul pour cette question intéressante. Effectivement, comme Bélizer vient de le dire, nous avons beaucoup travaillé même avant l'arrivée du cyclone. Parce que la surveillance météorologique avait montré qu'il y aura des cyclones et nous nous sommes préparés. Je vous dis que je suis dans l'océan Indien il y a plus de 10 ans, mais la façon dont on se prépare maintenant et il y a 10 ans, c'est totalement différent. Il y a 10 ans, les cyclones venaient même surprendre les gens. Maintenant, quand il y a des cyclones, on prépositionne déjà les intrants et les médicaments. On prépositionne les tests de laboratoire pour la surveillance. Et je vous dis par exemple que le cyclone de Madagascar, quand il a touché terre des années, le président de la République était sur place, il est allé attendre le cyclone pour se solidariser avec la population. Donc, vous voyez que c'est la planification, la surveillance et la formation des équipes d'urgence qui doivent être là, prêts pour répondre, tout en prépositionnant les intrants. Maintenant, je voudrais revenir sur un élément important par rapport à cette question. Comment éviter ça dans l'avenir? Vous savez, les cyclones, on ne va pas les arrêter avec le changement climatique. Il y a une situation de changement climatique qui est évident. Bien sûr, on travaille sur ça, mais on doit voir comment aussi faire des constructions anticycloniques. Et à titre d'exemple, ici à Madagascar, on a construit des modèles de centres de santé qui résistent aux cyclones, des écoles qui résistent aux cyclones. Et on demande aussi aux habitants de construire des maisons qui résistent aux cyclones. Et curieusement et intéressant même, c'est de voir que ces centres de santé et ces écoles qui avaient été construits avant pour résister aux cyclones ont été les abris de la population. La population est venue se réfugier dans ces écoles et ces centres de santé qui abritent et qui sont résistants aux cyclones. Alors, si le gouvernement, à long terme, peut penser à avoir des structures de santé, des écoles, et demander à la population de construire de façon à résister aux cyclones, ça serait des mesures qui vont être des mesures de prévention importantes, effectivement, pour éviter les destructions des structures de santé telles que ce que j'ai cité, les 2 hôpitaux de référence qui sont détruits et 36 centres de santé qui sont détruits. Ça, c'est des mesures vraiment à prendre à long terme. Mais ça mérite un investissement majeur. Over to you.
Merci beaucoup, Dr. Laurent. Dr. Severin, can you give us briefly the situation in Mozambique? Over.
Yes, and I very much concur with what Dr. Laurent has just said. So I won't repeat the things that also apply to Mozambique, just to reconfirm that even in the 4 years that I've been now working in Mozambique, from each year, the predictions have becoming more precise and more anticipatory. There are 2 elements that I would like to stress. This is clearly a result of international multilateral collaboration, because the meteorological prediction obviously is thanks to technology advances and improved IT and even in artificial intelligence capacity. But obviously it's a result of international collaboration that countries share their meteorological data. So I do think even now we have predictions of a depression zone in the Indian Ocean close to Madagascar that could or could not develop to a tropical storm or even a cyclone. So I think this is very closely monitored, and this information is also shared with the countries in the region, but also with partners. Here, for example, I'm on a WhatsApp group, or actually it's a Signal group, where I do receive all the prediction of the National Institute of Meteorology, and which is beyond the responses being coordinated by the institution that I already mentioned, the National Institutes for Disaster Management and Risk Reduction. So I think the multi-sectorial and international collaboration is essential for promoting that. And just for talking about the international collaboration, also, for example, for the floods, the information that was shared by South Africa and Zambia and Zimbabwe with Mozambique was extremely important to predict some of the floods, to call for evacuations. And similar to what Laurent mentioned, well, the national authorities were very aware, and we knew already where the cyclone Gizani would be hitting the country. But the same was the case for Freddy. But also there, the minister already traveled the day before to make sure that the response is rapid and adequate. And I can only also reconfirm the importance of pre-positioning medical supplies, equipment, diagnostic things, and even staff in the areas that are likely to be hit. Over.
Thank you so much, WR. I now see that we have a live question from Bella Twin. Bella, please go ahead with your question.
Hello. Hope everyone is doing well. I'd just like to ask that a World Health Organization strengthening
Bella, if you can approach can you approach your mic? We can't hear you
Can
quite
you hear
well.
me?
Yes, please
Is
go
this
ahead.
audible? Okay, yeah. How is the World Health Organization strengthening border coordination to prevent or mitigate further regional spread of cholera and other diseases? What strategies are taking?
What I did here is about the strategies on regional coordination. It was a bit breaking. If that is your question, then I'm going to how WHO is strengthening
Cross-border
cross-border coordination to prevent further regional spread of cholera. Dr. Otim, we will send this question over to you. Please.
Thank you very much, Marian, and thanks, Bella, for the question. So, as was mentioned, of course, we have seen cross-border cholera transmission in the Southern Africa sub-region, but also in the Eastern Africa. Currently, we are looking at around the Lake Tanganyika area where we have transmission around the lake. There are two things that we've been doing. One is facilitating cross-border meetings and information sharing and joint action between the countries. Like here, we've had joint meetings and collaboration between Congo, Brazzaville, and DRC, between Mozambique and Malawi, between Mozambique, Zambia, and Malawi, and also between South Africa and Zimbabwe. But now, taking this further, we have looked at the lessons from Mpox response as well as from the COVID, that we need to have this framework of collaboration further really institutionalized. And currently we are working together with Africa CDC on a regional collaboration framework for coordination and information sharing and synergized action during emergencies response. This is at different stages of review by the member states, and we hope that towards the end of this year in August, that this will be formalized into an MOU that lays a clear structure of how we should coordinate, for instance, for cholera, synchronized cross-border vaccination. If there's an outbreak across the border, the other side, and they are vaccinating, they should be able to synchronize with the county or district across the border, the other side, and so that we can, because of the high population movement across this border, so that we can really mitigate the risk of transmission. But also, secondly, is the sharing of resources for faster response in terms of laboratory, in terms of treatment facilities that patients can be able to access these quite quickly. Also sharing surveillance data and coordination mechanisms. So those are all aspects that have been put in this draft framework that is currently under review. And we hope it can really institutionalize this so that we move from ad hoc coordination between member states bilateral engagement to a more continental-wide approach that is entrenched in a formal memorandum of understanding adopted by the member states. Thank you.
Many thanks, Dr. Otim. I will move over to Dr. Belize if you want to weigh in.
Okay, thank you so much. I think Patrick mentioned what we are really doing in an operational way, but I really want to recall again that we have the IHR, the International Health Regulation, and cross-border is sharing information, data, and avoid a spread of cross-border disease is also one of the bases that we have the International Health Regulation. I also want to recall that at every country in the world, not only in Africa, we have the national focal point. And now we are moving to the national IHR authority. So the national focal point is not a person, is an institution in each country. And all the data, when something happening in a country, all the data is sharing by those national focal points. And we have also internal process where we share the description of this data. That means the data is sharing in a very real-time basis that allow also the country, the bordering country also to take action when there is something ongoing. The other things also I can add is that we also, Patrick mentioned, we've mentioned it, is that we harmonize case definition. in order for the country who are having the disease have the same case definition. It's very important. When an outbreak, the case definition should be the same for the disease to mean the same for all those countries having that. And I think this is what I can say. As you know, the IHR has been revised, I think last year, and has been approved, adopted also by the country. Now we are in the implementation again, and we will have a meeting with all national focal point that will be held, I think, I don't know the country yet, but in order to harmonize all those tools and also to harmonize the comprehension that we have behind the cross-border surveillance, the cross-border disease putting in place. Thank you.
Thank you so much, Dr. Belize. Dear friends of the press, we are now come to an end of this virtual press briefing. But before we close down, I will now turn it over to our panelists to get their final messages. Dear panelists, you've got a minute each, starting with you, Dr. Severin.
Okay, I think the main plea I have for the press is to spread the information, which is your responsibility. Working in a country that is being systematically, I think, overlooked with all the problems it's facing, and the decrease in humanitarian assistance globally, but particularly for Mozambique, I really would like to call to report on the situation in the country, the multiple disease threats, cholera. We have regular measles outbreaks, the humanitarian crisis and conflict in the north. I think there's a lot to report on, and people are suffering in Mozambique, and we need to get that better. Thank you.
Thank you, Dr. for that closing remarks. I will now pass it over to you, Dr. Laurent, for your final message, please.
Merci beaucoup. Le message, le dernier message que je peux donner ou le message final, bien que la réponse soit en cours, il reste encore des besoins très importants. Nous faisons le maximum, mais nous avons encore besoin de renforcer la coordination parce qu'il y a parfois des partenaires qui peuvent venir s'installer sans respecter le système de coordination qui a été mis en place. Nous avons encore besoin d'un appui logistique qui est soutenu et des financements additionnels. Nous avons lancé un appel Flash Apia qui va jusqu'autour de 70 millions de dollars. Et nous avons vraiment besoin de cet appui qui sont essentiels pour protéger la population et surtout les populations les plus vulnérables et affectées. Et prévenir une détérioration de la situation sanitaire et surtout éviter les nouvelles pertes humaines. Et je pense que les journalistes peuvent nous aider dans la communication, transmettre les informations et nous sommes disponibles à répondre à leurs appels. Merci beaucoup.
Merci beaucoup, Dr. Laurent, pour ce message. Now, passing it over to you, Dr. Belize, for your final message.
Okay, thank you so much. I want to say thank you to all the journalists who joined us today, and thank you also to my colleagues and panelists. So my message, what I want to tell everybody is that public health security is a shared responsibility. Is our responsibility, but it's also our media colleagues' responsibility. So we really count on them in order to share the right message, to the right information to the community. Actually, in WHO, we put access to information as a part of a community protection aspect. So it's really important, and we really count on them. And we really say they are very critical partner for us. We really want to work with them. Reason why we have this briefing, we will continue doing it, and we are available to respond to their question. And I really want to emphasize in their role as amplifier. I don't know, it's amplifier, accurate amplifier of the message of the health and system. So thank you again, and thank you so much for being with us today. Thank you.
Thank you, Dr. Belize, and many thanks to you all, our dear panelists, for the information shared today. Thank you to everyone who participated and engaged with us during today's briefing, and see you at the next press briefing. Bye-bye.
Bye.
Thank you. Bye-bye. Bye.
Au revoir.
Au revoir.